At Gilead, we have been committed to delivering person-centric advances in HIV research for more than 35 years. Our latest innovation spotlight will focus on the concept of drug resistance. Drug resistance can impact the selection of treatment regimens and is an important area of our long-term HIV treatment research. HIV drug resistance is caused by mutations in the genetic structure of HIV that may affect the ability of medicines to block the replication of the virus. All antiretroviral drugs, including those from newer drug classes, are at risk of becoming partially or fully inactive due to the emergence of drug-resistant virus. Today's treatment regimens are highly effective at lowering the amount of HIV in the body when taken as prescribed. However, the virus may be resistant to treatment for several reasons, including past treatment failure due to resistance development, challenges with medication adherence, or acquiring drug-resistant strains of virus. If HIV does begin to replicate once again, the virus may also gain the ability to evade certain medicines that were previously effective. This creates the potential for development of resistant strains of the virus that may be passed on to others who also may now have fewer effective treatment options available to them. Drug resistance is a key area of focus for our long-term HIV treatment research. Scientific discovery will have the most significant public health impact in minimizing the effect of HIV drug resistance on the global treatment landscape and get us one step closer toward the ultimate goal of ending the HIV epidemic for everyone, everywhere.
People often say, everything is fine. But then again, they also say things like, we're loving this. And, great idea, boss. Then there are those who reply, looks great. Or say, close enough. They tell themselves, I'm all right. I'm all right. Still all right. While others answer, so good. Some respond with, I can make it work. And every so often they say, that's nice. Then there are moments when people say, this will be okay, even when they think it won't be okay. So when people say everything is fine, is it?
At Gilead, we have been committed to delivering person-centric advances in HIV research for more than 35 years. Our latest innovation spotlight will focus on the concept of drug resistance. Drug resistance can impact the selection of treatment regimens and is an important area of our long-term HIV treatment research. HIV drug resistance is caused by mutations in the genetic structure of HIV that may affect the ability of medicines to block the replication of the virus. All antiretroviral drugs, including those from newer drug classes, are at risk of becoming partially or fully inactive due to the emergence of drug-resistant virus. Today's treatment regimens are highly effective at lowering the amount of HIV in the body when taken as prescribed. However, the virus may be resistant to treatment for several reasons, including past treatment failure due to resistance development, challenges with medication adherence, or acquiring drug-resistant strains of virus. If HIV does begin to replicate once again, the virus may also gain the ability to evade certain medicines that were previously effective. This creates the potential for development of resistant strains of the virus that may be passed on to others who also may now have fewer effective treatment options available to them. Drug resistance is a key area of focus for our long-term HIV treatment research. Scientific discovery will have the most significant public health impact in minimizing the effect of HIV drug resistance on the global treatment landscape and get us one step closer toward the ultimate goal of ending the HIV epidemic for everyone, everywhere.
People often say, everything is fine. But then again, they also say things like, we're loving this. And, great idea, boss. Then there are those who reply, looks great. Or say, close enough. They tell themselves, I'm all right. I'm all right. Still all right. While others answer,
Hello，
so
大家可以，我哋下一節可以開始㗎啦。咁麻煩大家可以坐返低。係，our next session's about to start, so if you can take a seat, we can begin. Take a seat, please. Hi, take a seat.
this will be okay, even when they think it won't be okay. So when people say everything is fine, is it?
Hello. Hello.
At Gilead,
大家可以麻煩
delivering person-centric
Hello?
advances in HIV research for more than 35 years. Our latest innovation
可以麻煩大家坐返低，
concept
我哋下一個 session 開始㗎啦。
resistance can impact the selection of treatment regimens and is an important area of our long-term HIV treatment research. HIV drug resistance is caused by mutations in the genetic structure of HIV that may affect the ability of medicines to block the replication of the virus. All antiretroviral drugs, including those from newer drug classes, are at risk of becoming partially or fully inactive due to the emergence of drug-resistant virus. Today's treatment regimens are highly effective at lowering the amount of HIV in the body when taken as prescribed. However, the virus may be resistant to treatment for several reasons, including past treatment failure due to resistance development, challenges with medication adherence, or acquiring drug-resistant strains of virus. If HIV does begin to replicate once again, the virus may also gain the ability to evade certain medicines that were previously effective. This creates the potential for development of resistant strains of the virus that may be passed on to
Hi
others who
everyone,
also
welcome back. We're going to start our next sections on mental health soon, so please be seated. Okay, welcome back everyone. So we're going to start our first conference section. The theme of this part is the interconnections of mental well-being and sexual health. So I would like to introduce our moderator of this panel, and then she will help us to introduce our speaker of this panel. So Amy is the assistant manager of POHIV team at AIDS Concern. She is a public health practitioner and a social worker with over 8 years of experience working in NGO organizations, doing drug prevention, sexuality education, as well as the LGBTQ plus counseling. So welcome, Amy. And then the title of this section is very interesting because we are talking about bringing in the concept of quality of life. So it's improving the quality of life of POHIV from the meso and macro perspective. So welcome Amy on board. Yeah.
So to kick off our first session, the interconnections and well-being of mental health and sexual health, I'm honored to invite Dr. Crystal Lee and Odile Thiang to the panel discussion to share their expertise on improving the quality of life of PLHIV from the meso and macro perspective. So Dr. Crystal Lee and Odile. So Dr. Lee is a specialist psychiatrist and a fellow in community medicine. Prior to her psychiatric training, she focuses on HIV prevention and surveillance in the Department of Health. And on community-basis HIV epidemiology studies in the Chinese University of Hong Kong. Currently, she is the member of the Medical Advisory Panel for AIDS Concern, and she's providing consultations in the Queen Mary Hospital and the Integrated Treatment Center. Dr. Lee published an article last year looking into the intersections between mental health, substance use, and sexuality, and the study focuses on the recovery process of HIV-infected MSM with history of chemsex. And Odile is a very experienced pediatric nurse practitioner with over a decade of hands-on experience in Toronto and Hong Kong. Odile is a teaching fellow at the Hong Kong Polytechnic University and an honorary nurse consultant at the Hong Kong Children's Hospital. She has robust experience in clinical care, quality improvement initiatives in healthcare, and mental health stigma reduction education. Her commitment to serving marginalized community lead her to work with survivors of sexual violence and domestic violence and vulnerable LGBTQ+ youth. As the lead clinical advisor on anti-stigma and training at Mind Hong Kong, Odile actively advocates for affirming and safe mental health care for LGBTQ+ communities. Introduce myself again, I'm Amy. I'm the assistant manager for the PLHIV support team. And from my work experience, I've encountered people living with HIV of diverse backgrounds, age, and gender identity and sexuality, from newly diagnosed to people living with HIV for decades. The psychological distress is common among newly diagnosed and people living with HIV for over a period of time. They have an increased risk of mental health conditions, so I'm honored to be able to learn from two experts in the mental health field. So I think I would like to ask Dr. Lee first. What is your experience in working with PLHIV? What is their journey look like in the medical system and community? And are there any common challenges they are facing?
Thank you, Amy, and thank you, AIDS Concern, for the very kind invitation. So what's my experience with working with PLHIV? I need to put up some slides to guide myself talking. So I've been in the field for many, many years. My first experience was with PLHIV, was with patients with hemophilia. I'm not sure if any of you have come across patients with hemophilia and HIV in your practice. It's been, I was counting, 40 years since they contracted HIV in Hong Kong. And at that time, 20 years later, when I first joined the SPP, I met most of them, I think 20-something, if I remember correctly. As a very junior medical doctor, I was talking to them, and they told me all the stories, all the discrimination, all the mental problems, all the physical disabilities they have been facing. And I was very touched by each of their story. I think that what they have gone through is very unique. It's like an iatrogenic infection, and at that time it was a fatal illness. It was a fatal disease. Everyone was like very hopeless, and they were struggling with life, their families, their work. So that was my very first impression of HIV infection. I mean, people with HIV. I don't know if any of them are still here today. It's been 20 years, it's been 40 years. I still remember most of them, their stories, and I was very touched by them. And I was very struck at that time. And that's what Dr. Ho was mentioning, the ex gratia payment they have been receiving. And we actually, from that study, we increased like more financial support to them, and we coordinated all the medical services they have to go through, from orthopedics, medical, and then liver problem, hepatitis C, and then HIV. So many problems, and then we try to delink the problems they get through services and to smoothen the coordinated care they were experiencing. So that was my very first impression of mental health, HIV. They were full of anger. They were so pessimistic about their future at that time. And then the second experience of pediatric HIV I had was the the MSM, the epidemic that started 20 years ago. So again, I interviewed some of the patients, how they acquired HIV through parties. At that time, ecstasy, ecstasy. Just thought it was a party thing, happy, recreational. And then they didn't think about having HIV at that time. And then 20 years later, of course, is the chemsex Dr. Ho has mentioned. The patients that I've been seeing are suffering from meth addiction, meth dependence, depression, psychotic disorder. And many of them thought they should be quitting, but it's so difficult. And they have gone through like different stages in abstaining, relapsing, abstaining again. And of course, struggling with whether I need to tell who is supportive, who may not like me at all. And then just 2 words about the last one is the female sex worker. Again, Dr. Ho mentioned, so I mentioned it again. I was working with another NGO, and then we detected some HIV infection in female sex worker locally 2 years ago during the COVID. I just want to mention one point is that after we told them, oh, this is HIV, and then we took blood, it's confirmed, they disappeared from the NGO. We transfer them to, we refer them to the clinical service. They were there, but then we lacked, we became disconnected from the community. Perhaps that highlighted the stigma, the self-stigma. They don't want to be known to others, get in touch with others. I don't want to talk about HIV because the NGO, one or two staff would know about their status, and they get disconnected. So perhaps that's one story that reflects the self-stigmatization that I saw from the female sex worker infections just 2 years ago in Hong Kong.
Yeah, that's very true. I think from our experience, we have trouble maintaining contact with newly diagnosed positive case from outreach, like mobile testing. Oftentimes, they gave us a fake number, and then we wouldn't be able to contact them. Or after a few contacts, they blocked us. And then actually sometime maybe half a year later, we received a text from the phone, and then they came back asking I got some symptoms, and how do I access healthcare and stuff like that. So that does reflect the self-stigma or the self-isolation and mental health condition when they newly diagnosed. Yeah. So I think, Odile, you have more experience working with LGBTQ+ folks. So I want to hear your insight on, is there any challenges they face that is a barrier to their sexual well-being?
Yeah, so I'll segue from your talk about stigma and continue it. Stigma is everything. When we're talking about health in general and sexual health. I think oftentimes we don't associate stigma. We just think about it as this is just a health problem. But stigma is everything. Stigma is going to impact, from a macro level, it's going to impact policies. It's going to impact financial distribution. We were talking about that earlier this morning. And on an individual level, it impacts how a person actually gets to explore their sexual health. So individuals within the LGBTQ community don't actually get to naturally explore their sexual health and sexual preferences in a healthy way, meaning that throughout high school, they generally have to stay closeted, either because of bullying. They have to stay closeted from their family members, so they don't have these conversations at home either. And so what happens is when we have to go into the shadows, that's when issues arise, right? You might be engaging in chemical sex, like we talked about this morning and just now. which is a much more risky behavior. Because you don't have like the interactions that other cisgendered hetero youth will have in high school. You don't get to like go to a guy or a girl and say like I kind of like you, start dating, doing like those natural progressions, right? It has to go underground. The other issue as well is we are not really good here in Hong Kong at sex education to start with. And so even if they do get some information on sex education, they get it from a hetero perspective. And so individuals who are not engaging in heterosex don't actually understand what are their risks and what are they what do they need to do to keep themselves safe, because we're talking from a very, very specific lens, which does not speak to them. I'm just going to go back really quickly to the chemsex. A lot of the issues with chemsex is the community that is engaged in chemsex, they're engaging in it because of kind of underlying anxieties, underlying stigma and self-stigma, using substances to either ease anxieties around these interactions because they don't get to have them in like a normal setting on a day-to-day basis. And so that's sort of, it comes back to the stigma, the self-stigma, the homophobia, internalized homophobia, and other kind of communication that they're getting from their environment. So I think it really, it's everything. And one of the reasons that got me on sort of my allyship journey was it was in my first 2 weeks of becoming a sexual assault nurse examiner, and I was called in at midnight. I got a page, and the dispatcher said, you need to come in. There is a young man here wanting to talk about a sexual assault. And I thought, oh my God, it's a guy. Most of my patients during my month-long training were all women. I had lots of patients, but they were all women. We did have lots of training about LGBTQ concerns, so I had to kind of dig deep and kind of think about, okay, what do I need to do if it's a guy? Okay, it's the same thing, but what have you. And when I got there, we started chatting. We talked about his interaction. And what happened to this young man is something that I've heard over and over again. I've heard it from my own friends. He, got this date online, went to a neighborhood that he's unfamiliar with because, God forbid, should he be seen in his own neighborhood with another person, another guy. The person that he met there was not who he represented online, and then he was assaulted. Right? So when you're not able to explore your sexuality in a healthy and natural way, you have to kind of do it in the dark, do it in the shadows. We were able to connect because I had to talk to him kind of as a girl about, safety and dating. But when you're in the shadows, you don't get to have those conversations with your friends. I had those conversations with my girlfriends like, what do you do when you go on a date? What are precautions that you take? You make sure you have extra cash so that you can get out of there. Or a girlfriend would tell me, do not meet this guy, it sounds really sketchy. But they don't get to do that. And so we have to be really cognizant of really working on the community, really working on the population at large and reducing the stigma both of mental health and of sexually transmitted infections and LGBTQ identities.
Yeah, I think the lack of inclusion, diversity of no matter gender or sexuality, and also maybe neurodivergent inclusiveness is causing people to not be able to say what they are experiencing. They kept closeted, and the risk of turning to substance use would be high, and having other mental health condition would be high. Yeah, so we talked quite a bit about interpersonal and self-stigma Dr. Lee, I wonder, like, if PLHIV or LGBTQ plus folks are facing some structural stigma coming from cultural, social, and legal factor, and on a macro level, how can we improve the quality of life of PLHIV folks?
Very difficult questions. Anyway, so I was thinking all the self-stigma, discrimination, closeted. So whether you're just being not the majority in the group because you are like having different like non-heterosexual, or having an HIV infection, so that actually put on much more extra stress on your psychological demand. So I just listed out some of the issues that I thought of for PLHIV, for example. So the issue of discrimination, and I remember Amy also told me, PLHIV would have problems getting into elderly home. Say, the elderly home may check their medical history, and then infection. I don't know. Maybe Amy can share a little bit more. But then they just go through all the social services, medical services. They always have to decide whether I should reveal my HIV or whether I should conceal. So that put an extra stress to it, because this with you every 24 hours every day for every day in a year, you have to think about whether you should tell people or you should conceal. I think that's a lot of stress for anyone. And apart from overt discrimination, I think bad attitudes, it's one of a very important sort of stress as well. So think about, for me, I say 肥妹, say 你好醜樣, okay? So all these kind of bad attitudes, 你咁肥行開啲, okay? I mean, if that refers to your sexuality or HIV, say, I think that would be really sad, especially if I were really young and I'm not resilient enough and I'm not having good support from my friends. That would be really stressful. Other worries about future, right? I'm alone, I don't have a partner, I'm HIV, I'm not lovable. No one would love me. I worry about transmitting to others. So worries about future. I mean, I also worry about my future. I mean that having HIV or being not a majority of the population, I think that would really create extra worries for them. And from my experiences working with PLHIV, I think some of them would have a lot of stigmas and different meanings attached with HIV, the virus. Many of them would have shame, feel shame and guilty. And the core value we talk about is that I'm not lovable, no one will love me. I think that if having that concept for the rest of your life is so distressing and is so dark. So I think all these would create lots of demands psychologically for PLHIV. And if you are not being resourceful enough, you are not resilient, you don't have a good supporting network, you don't accept yourself having the virus, you don't accept yourself being gay, and you don't know how to solve them. You don't know how to solve. I don't have place to live. I don't seek Amy's advice. I don't go out to ask a district councillor for help. So that would be really stressful, having a stressful situation that may really hamper their quality of life and mental health. But of course, there are situations or there are individuals who are really resilient, having good problem solving, self-acceptance. They may turn that around, and they would internalize that, it's okay, I understand why people are doing this, I still have many good qualities, I still have many good friends, and they can move on. So I think that's the issues that they were facing, and if they are not being resourceful, that would create lots of mental health stress for them. I should go on, yeah. So what can be done to improve the quality? So I searched like AI, and then I was thinking how to change the social environment, being more supportive and less discriminating. So I think that's a very good model for me to talk about how we make change, improve like acceptance. So that's the social change model that talks about individuals, group values, and societal values. So if each of us can embrace the compassion and then find some groups to collaborate with common purpose, and through that interaction, we can perhaps bring about change in the society for the common good. So, of course, everyone in different positions in the society, I think they have different methods to work with the people around them. Maybe in your school network, your friends, your office, in your reaching out to other groups. So all these would make changes in the society. I was searching that what's actually acceptance, like what should we do? It was back in, again, many old days. I mean, old days, 23 years ago, we already set a paper by the ACA at that time that what's actually promoting acceptance. They have listed out all the principles, things should be done, but two of the principles are listed here is that non-discrimination is not limited to anti-discrimination, but also with positive qualities of equality that we talked about this morning, compassion and mutual respect, and acceptance of whatever people entails a change of attitude, cultural norms and values. So I think that would be that can guide we go forward. What should we be going through? And Dr. Ho mentioned the ACA. Of course, this is one important chapter in the strategic area, that we should work on the policy, we should build our capacity, we hopefully can change some guidelines, regulations, we go on to have media campaign. These are some of the things that we can work through in a more macro perspective. Yeah, so that's how I think being individual or affecting your groups and we can make a change in a society.
Yes, that's very true. To promote inclusion, diversity, and doing anti-stigma education is very important. And I believe our small efforts as an individual in the system, and then slowly we can build bigger changes and a better environment for people of different diversity. So we have mentioned quite a bit of concept of intersectional. Sorry, I'm tricking up on this word. Yeah, intersectionality. Yeah, that's a very tricky word. Yeah. So in the context of PLHIV and LGBTQ plus folks, it basically means there is a complex cumulative way in which the effect of multiple forms of discrimination and oppression would overlap and intersect to create unique dynamics and inequalities. For example, an elderly gay person living with HIV, living in an elderly care home, with their adult child all away overseas, never knowing his own status. Or a 30-year-old woman newly arrived in Hong Kong, needing to disclose her HIV status to her husband because they're planning to have a child. It's multiple factor, multiple identity, all overlapping and really complex situation. And everyone is experiencing their unique experience and oppression. Yeah. So my question for Odile is, in response to the intersectionality, I got that right, how could we respond on an organizational level?
So I think the most important thing is to remember and understand that no community is a monolith. And the LGBTQ community is not a monolith. Even within the alphabet salad of LGBTQ, you have almost hierarchies of privilege and hierarchies of marginalization. So, for instance, we have gay men who, just by the virtue of being men, have a certain amount of privilege, and that kind of translates into the general, how the general population kind of sees them. On the other end of the spectrum, we have transgendered, women, and particularly if these transgender women are associated with an ethnic minority. And so you have kind of layers and layers and layers of both marginalization as well as privilege in certain cases. So understanding that is really important, which also means that it's really important for us, if we're talking from an individual level, to, one, do a really good psychosocial assessment of that person to understand what are the stressors that are impacting their day-to-day lives, and not just assuming what they are. From a more structural perspective, I think it's really important for us to never, ever, ever embark on doing anything towards a community without having the community say, fully embedded in it. So nothing about them without them. I have seen quite often very well-meaning people in privileged positions that are not within the community who want to be allies and who want to support, embark on kind of, strategy or kind of projects, but never actually asking for the needs of the community. And when we're asking for the needs of the community, we have to make sure that we're not just asking like the gay guy that's like around, but we're asking like a wide variety of individuals so that you're getting those layered responses and layered feedbacks about the services that you're about to provide or the changes that you're trying to make. The other thing that is really important is to always have a trauma-informed approach when we are, either dealing with an individual on an individual level or on a more structural level. And a trauma-informed approach just means that we are understanding that there are, because of all these intersectionalities and because of all these layers of either of marginalization, people are coming in with their own sets of either small t or big T trauma associated with their different multiple identities. So, just keeping that in mind and not just painting everybody with like one broad brush stroke and making assumptions. So really important, getting the perspectives of the people that we're trying to support.
Yeah, getting the consumer perspective, never assuming, and like creating a safe and inclusive environment for the people to be themselves, like in like a safe space and in the community. Yeah, so it was a great discussion. Too bad we have a limited time. So I think just to wrap up, is there any take-home message for the audience?
Already prepared. So, and it's a summary of what we have talked about already, right? HIV is not a priority health topic. Dr. Ho mentioned that. I think that's a very important part, that how we can strike among different competing challenges. And specifically for HIV, or like sexual mind, or I think more for HIV, that patients are highly invisible. I think that's a very important part of the issue. I mean, for SMA, people can go to yes, you can go to東張西望 and then talk about, oh, it's a very sad story, we don't have money, and then people will donate. And remember, in the past, the newspaper that have already been like disappeared, they also have some donation, 送亂, and people can make their stories out and then ask for compassion from people in the media publicly. But for HIV, I think that's like a different story. It's very difficult for them to talk about their difficulties public. I hope we can, like, if I talk about that thing, if we have some people who can like cope with that it's okay, it's infection, be a very strong, resilient, self-acceptance patients can come out and talk about their difficulties for the community, and that would help us compete for these resources with compassion, because we thought people should have compassion, right? And each of us, before we do that, perhaps we can all be the agent for change in various groups, as I've mentioned, maybe in your social network, your office, your nurses, your staff. I think from what you practice and believe you can cultivate and influence change in the people around you. And embrace compassion and mutual respect as really the most fundamental value of your professionalism and the wider society as well. And then with that, I hope we can make some change in the community.
So I'm going to give my kind of final thoughts from a cisgendered hetero woman perspective. What I have seen from working with the LGBTQ+ community is an immense level of resilience. Not weakness, not, there's struggle, but an immense amount of resilience. So from my perspective, they don't need allies to do anything for them. They need us to walk alongside them and help with our privileged position to elevate their voices and allow them to speak for themselves.
So thank you, Dr. Lee and Odile. So I think we'll wrap up this session and we'll join Dr. Gordon Wong after together for an Q&A session. Yep.
Thank you, Dr. Lee, Amy, and Odile. Okay, so we'll now invite our next speaker, Dr. Gordon Wong. He is a specialist in psychiatry and also the honorary clinical assistant professor in the Department of Psychiatry at Li Ka-shing Faculty of Medicine, the University of Hong Kong. So Dr. Wong will equip us with some tips in supporting the mental health of PLHIV in Hong Kong. Dr. Wong, please. Thank you.
Thank you very much for the introduction. I'm very honored to be here. Thank you very much. Thank you. So, do I press here? Or, oh, yes. So thank you very much, and I'm Gordon, and today I'll share with you some information and insights in mental health in people living with HIV. So there are three parts to my talk. The first part is people living with HIV and mental health problems. So people who do live with HIV, they do experience quite a few mental health problems. So people with HIV commonly have mental health problems, as I will talk about in a minute. And also, people who have mental health problems are at higher risk of acquiring HIV. So it's like a vicious cycle where people who have mental health problems, they get a higher risk of HIV, and then when they have HIV, they have a higher chance of mental health problems. So it's a cycle that doesn't seem to end. So as professionals, we have to do something to help these people who are experiencing challenges. And one of the challenges that people may experience is that LGBT people are often marginalized and often facing discrimination, and therefore that would in turn increase the risk of mental health problems as well. So it's like a perfect storm where all these factors, intersectionality, as Professor Lee has already mentioned, they really brood together and create a lot of mental health problems. So over time, over the spectrum of time, people who do have HIV, people who get infected with HIV, they may, at first, when they find out about the diagnosis, about the presence of virus in their body, they may experience adjustment problems, such as adjustment disorder due to newly diagnosed HIV infection. And over time, there could be a lot of anxiety, a lot of depression because of all these different stresses living with HIV. There may be like discrimination, marginalization. And over time, there could be shame, disgust. There may be self-stigma. And therefore, people isolate themselves. They don't want to tell anyone about their HIV infection. They isolate themselves from friends, from family, and they may feel very guilty or having contracted the virus. And I will talk about that in a case I will share in a minute. And over time, some people, on the other hand, on the other end of the spectrum, some people may feel that they have to do something to make themselves healthy, make themselves as healthy as possible so that the virus doesn't affect their daily life. So they may do as much as possible to stay healthy. They may exercise a lot. They may eat very healthily. They may take a lot of supplements. And because they want to stay so healthy, they may have a lot of health anxiety when they have the most minor physical problem. When they have a headache, they think, oh, is it HIV? When they have an itch on the skin, oh, they think, oh, is it HIV? So that could be the other end of the spectrum. And so there can also be substance abuse, substance misuse, or chemsex, because some people may think that, oh, now that I have HIV, it doesn't matter anymore. I can have as much sex as possible. So that could also lead to other problems, like such as superinfection, and also substance misuse problems like psychosis. So that can also lead to many other problems. And over time, because HIV directly infects brain cells, there can be cognitive problems such as memory impairment, language impairment, attention problems, and I'll talk about these in a minute. So in psychiatry or in mental health in general, we often devote our time in depression and suicide because suicide is like the ultimate outcome that we want to prevent. And in people living with HIV, it is actually very common to have depression. So 30 to 50% of people do experience depression, a major depressive episode, sometime after HIV infection. So one third to a half of people with HIV experience depression, and that is very common, so we have to actively look for it. And suicide is a symptom, a behavioral manifestation of depression. So, and in people living with HIV, there is a 9 times increased risk of suicide. So that is also something we have to look for. The risk factors of suicide include younger age, because people who are younger, they're often more vulnerable. They may not have the psychological or material resources to cope with the diagnosis, to cope with the problems associated with HIV. There can psychiatric illness, as I said, is very closely linked to HIV infection. Social isolation because of self-stigma, stigma from the society, that also increases the risk of suicide, and also exposure to some antiviral and antiretroviral medication that also can increase the risk of suicide. So we have to bear that in mind. Apart from depression and suicide, there can be other mental health issues related to HIV as well. So one issue is mania. Mania is the opposite of depression. So a lot of people have a misunderstanding regarding mania. So in mania, in Chinese, 狂躁. And 狂躁, a lot of people think that 狂躁is irritability, is the tendency to throw temper. But the medical definition of mania is actually to have at least 4 days of sustained elated mood with a decreased need for sleep. And and irritability is only one symptom of mania. So we have to bear that in mind, the medical definition of mania in mind. So mania can occur as a part of HIV psychosis, or it can also be a side effect of a retroviral medication. So that is something to bear in mind as well. Another manifestation, mental health issue, is anxiety. So people who do live with HIV, they can experience a lot of different anxieties. Biologically, the anxiety could be a generalized anxiety disorder, meaning that the person is anxious like all day, every day, most of the time, like being anxious for no reason. There can be panic disorder, which is an intense bout of anxiety that seems to come out from nowhere, generally lasting about 20 minutes. There can be post-traumatic stress disorder and obsessive-compulsive disorder, and that is also classified as anxiety. For HIV infection, because the HIV virus affects basically the whole body, so that could be chronic pain as well. And studies suggest that 80% of people living with HIV experience chronic pain. And when you live with chronic pain, people just take medication to relieve the pain, and that can lead to that can be a risk factor for substance misuse. Another mental health issue that may manifest itself is delirium. Delirium is an acute confusional state, which is fluctuating. It fluctuates like from hours to days, so the manifestation of delirium can change within hours. So up to 30% of AIDS patients have delirium, so it is quite common as well. And this delirium, this acute confusional state, can be caused by directly by the virus. It can be caused by secondary infections in the brain, that may be due to tumors or substance withdrawal when people take substances, such as alcohol or some other anxiety medication. If they stopped cold turkey, then that may cause withdrawals, which may cause delirium. And another issue is psychosis. So that can be a feature in early HIV-associated dementia. And also, that can also be caused by substance use as well. I remember a case where, when I worked in the public hospital, there was this 21-year-old guy who was admitted for psychosis. So he lives with his family members and also the boyfriend in the same bedroom. So the family is very progressive. And so he was admitted to the hospital because of abnormal behavior, not sleeping, trashing the flat, and he was admitted to the hospital. And so it was known that the person, this 21-year-old guy, had HIV. So at that time, I thought it was HIV psychosis. And then I gave him medication to treat the psychosis, and then his symptoms quickly subsided over like a day or two. And then so I let him go, let him be discharged from the hospital, and then some days later, the urine toxicology results showed that there was amphetamine in the urine. So actually it was chemsex causing the psychosis, but he didn't tell us at all. And because urine toxicology results takes quite a few days to arrive, like a week to arrive, so by the time the results arrived, he was already discharged. So that was quite a memorable case for me. So next, I would like to talk about HIV-associated neurocognitive disorder, which is also a manifestation of HIV. So HIV virus actually enters the central nervous system very, very soon after the first infection, after the primary infection, and then it stays in the brain. So the brain cells are directly infected, and it also causes neuronal loss. So that's why there is neurocognitive symptoms in HIV, people living with HIV. So it is actually quite common. So 30% of people who have HIV-associated neurocognitive disorder, these neurocognitive symptoms are the first complaint, the first presenting complaint. So they go to the doctor complaining of symptoms that are not, but that are very general, and it is actually the first symptom that that is manifest in an HIV infection. So 30% of the people with HIV go to the doctor for the first time because of these neurocognitive symptoms. So it is quite a big proportion, and these symptoms are often very general, so it can be hard for the doctor to decide that these symptoms are actually caused by HIV. And then as time goes on, 70 to 80% of people living with HIV can develop some kind of a neurocognitive disorder, and at postmortem, 90% will have some changes in the brain, so it is quite a big issue. So when I say that 30% of the people first present with a neuropsychiatric symptom, neurocognitive symptom, so these symptoms include headache, altered peripheral sensation, leg weakness, and also seizures. So when someone goes to the doctor complaining of leg weakness or altered peripheral sensation, the doctor is not going to think about HIV as the first reason for these symptoms. And yet 30% of the people present to the doctor with these symptoms. 30% of the people living with HIV first present to the doctor with these symptoms. So I think this can be quite alarming as well. So as time progresses, there can be some neurocognitive symptoms such as cognitive slowing. They may think slower, they may be more forgetful, they may be more absent-minded, motor slowing, their actions may be slower as well. There can be poor coordination. They find that, they have tremors when they hold chopsticks, or when they hold a glass of water, they may find themselves having tremors, the water shaking. So they may also visit a doctor for these symptoms, and the doctor is unlikely to come up with HIV as the first differential diagnosis. And because these HIV symptoms is hard to pick up, and therefore with time it progresses to dementia-like symptoms such as cognitive symptoms, difficulty in performing daily tasks, difficulty in retaining information, learning information. They may find themselves forgetful. They may find themselves difficult to find words to express themselves. They may find it hard to read and write, misplace items. They may even get lost in the neighborhood. They may even have, in severe cases, hallucinations, delusions. There can be motor symptoms, movement symptoms. There can be affective symptoms, which means mood symptoms as well, such as depression, agitation, disinhibition, apathy. So there can be a lot of different symptoms. So HIV causes a lot of different psychiatric symptoms, and we really, really have to look out for these. So I've so far talked about the biological symptoms, but there are a lot of different psychological and social challenges of HIV as well. So for psychological challenges, there can be worries of discrimination, which we talked about just now, a lot of self-stigma, self-blame. There can be a lot of guilt as well. So I encountered one person who blamed himself for getting HIV, blamed himself a lot. He said he's always been careful, but there was one time in the gay sauna, he just let his guard slip, and then he got HIV, and he felt very sad, very guilty about that. And with all this background of discrimination, stigma, self-blame, that the person is understandably feeling hopeless, feeling helpless, and because of worries of this discrimination, they don't want to seek help, which I will talk about in a minute too. So when they don't seek help, and they feel helpless, they feel hopeless, and then the person may feel very depressed and suicidal. At the other end of the spectrum, again, there can be excessive health concerns as well. So I remember one case, not HIV, but HPV. So someone developed a tongue ulcer, and he basically was so convinced that he had too much oral sex when he was young, and therefore he had tongue cancer as a result of HPV infection. So that's the other end of that's excessive health concerns. So another issue, another psychological issue, another mental health challenge that people living with HIV may face is that because of their poor mental health in general, they may have a lot of depression, anxiety, shame, guilt. They may find that it's hard to seek treatment. They may find it hard to adhere to the treatment even if they seek it. They may feel that, there's no hope anyway. Why am I taking pills? I might just as well let the disease progress. Some people may think that, so that could be another challenge as well. Apart from psychological challenges, there can be a lot of social challenges. So we talked about a lot of stigma, discrimination, and that really affects help-seeking behavior. They may feel that they don't want to seek help, therefore they have no social support. They don't dare to tell anyone that they have HIV, therefore they isolate themselves from the society. And then another issue to think about is spousal acceptance. Is the spouse going to accept the HIV diagnosis? Because I remember one person who, I'll talk about that later in the case. So, and also there are other social challenges include barriers to treatment. A lot of people don't even know how to seek treatment. So you can't just go to any GP on the streets to get HIV treatment, and people don't know how to get it because there are specialized centers in Hong Kong to offer HIV treatment. People don't know how to access it, and the cost of treatment as well. HIV treatment can be very expensive if you choose to go private, and privacy concerns as well. Some people are very terrified of letting people know of their HIV diagnosis, and therefore the HIV treatment provided by the government is really good on privacy. So in the hospital authority system, like in the computer system, you can't see any record from the HIV clinic. So privacy is really a double-edged sword. So when I talked about the 21-year-old man earlier who had HIV, so we just had no idea he had HIV because he was treated in Kowloon Bay and the hospital authority could not access that record. So we just had no idea he had HIV initially, and then he said he had HIV, so if he doesn't tell us he has HIV, then we wouldn't know. And then so I remember another case who was admitted to the psychiatric ward. He was confused and didn't know what was happening, so he couldn't tell us he had HIV. He couldn't tell us he was on HIV medication, so naturally we didn't prescribe the HIV medication. A few days later, his mental state improved, and then he said he was on HIV medication, and then we were like, oh, okay, but the treatment was already interrupted by a few days. So this privacy has its pros and cons. And then, because of time, I'll skip through these special points to know. So I've mentioned that. So some HIV medication do have psychiatric side effects as well, such as depression, anxiety, and mania. So we have to pay attention to the iatrogenic side effects as well. And for local studies of people living with HIV, so I will just very, very quickly go through these because of time. So there are several studies that I know of that looked at MSM adults that were recruited from a specialist HIV clinic. So they looked at different mental health factors that affected mood, anxiety, and general mental health in people living with HIV. So one study found that stigma really increased psychological distress. So stigma includes in-group stigma, meaning within the LGBT community, within the HIV community, there is a lot of stigma between the community members. There were also a lot of stigma, internalized stigma, and also stigma from outside the LGBT group as well. There is also zero status disclosure concerns, meaning they are really concerned about telling people that they have HIV. And also negative medication reminder is also a source of psychological distress. Negative medication reminder means that when they take medication every day, they are reminded of, oh, I have HIV, I am diseased, I am ill, I did something bad, leading to this HIV infection, blah, blah, blah. So it reminds them of something negative every day. Another study also revealed that HIV, in people living with HIV, mental health is negatively impacted by similar stressors. Another study looked at a long-term relationship and mental health, and it found that having a positive love attitude, like relationship attitude, would have direct and indirect positive benefits on general mental health. So now I'd like to talk about the case I've been wanting to talk about. So it's a man in his 30s. So I actually encountered this man in Queen Elizabeth Hospital. And So I was asked to see this man because of, basically because of his refusal to see a doctor for HIV treatment. So he was found, I don't remember why he had some blood tests, but he had some blood tests in Queen Elizabeth Hospital, and he was found to have HIV several months ago, like 6-7 months ago. He was referred to the HIV clinic, but he refused to go. So I asked him why he didn't want to go. So he came up with various reasons. So he had low mood, he had a lot of anxiety, he had poor sleep, he ruminated about the HIV diagnosis, and he ruminated about, what am I going to do? What's my life going to be like? How am I going to tell my wife? So he had like a lot of mood issues, but he still but he refused to see a doctor for treatment. So even if Queen Elizabeth Hospital in the ward, they offered treatment to him, he refused. So that's why I was asked to see that guy. So I asked him, so have you really not told your wife? And he said, no, I haven't told your wife, but I haven't told my wife. But what about? So what did you do if your wife wanted sex? And he said he made various excuses not to have sex with his wife because he didn't want to infect his wife. But then he didn't want to tell his wife either. And then one thing that really distressed him was that he knew that his excuses wouldn't last. It's been 6-7 months already that he made excuses not to have sex with his wife. But the excuse is just, he's going to run out of excuses very soon. So that was really distressing for him that he had to tell his wife, and he didn't know what his wife would react. So that creates additional stresses. So there's biological stresses, there are psychological stresses and social stresses contributing to poor mental health. For the biological stresses, HIV may cause psychiatric symptoms directly. The psychological factors, the self-stigma causing him to not tell his wife, and social reasons, sociological factors causing poor health. He worries about how his wife will react, how people will discriminate him, and therefore all these contributes to poor mental health in this gentleman. So the take-home message is that mental health problems are very common in people living with HIV, and we really have to have a holistic appreciation of the emotional state in these individuals. We have to actively look out for mental health problems, and when we do encounter someone with HIV, perhaps with mental health challenges as well, we have to remember that we have to be professional, non-judgmental, and respectful. After all, we are treating an individual. We are interacting with an individual, with a person, and therefore we just have to be non-judgmental and respectful. We have to be empathic, try to understand what that person's feeling. We have to try to understand why that person's feeling this way, why this person's acting this way, and understand the presenting behavior and the presenting mood state. And we can try to help by increasing social support, maybe peer support groups or various NGOs for counseling. And if needed, we can also consider referring to a psychiatrist for management of mood problems or mental health challenges. And with that, I thank you for your attention. Thank you.
Okay, thank you. Sorry that because we overrun a bit, so Dr. Wong may not be joining us for the Q&A section, but welcome. If you have any questions for Dr. Wong, you can email us, and then I will deliver it to Dr. Wong, and we'll get back to you later. But now we have 5 minutes Q&A sections, so we can talk with Dr. Crystal Lee, Odile, and Amy. Just come up on the stage. Yeah. 5 minutes. Yeah. 5 minutes 就嚇，大家好好珍惜時間啊！ Anyone have any questions? Yes, you have some.
We heard all the challenges that people living with HIV are facing, and it's quite daunting, especially their mental health challenges, as we just also heard from Dr. Wong. I wonder, what are the success stories, and what is it that people benefit from the most when it comes to overcoming their internalized stigma and their related health problems? How do people, I'm sure there are people who are able to live with it in a more positive way. So from your experience, what is it that helps people the most?
Thank you for the question. I think this is a very important perspective too, like the success story of like people living with HIV. A lot of times from my work experience and like the experience of AIDS Concern, the social support is the most important thing that they need. An environment that they can meet other people with similar experience but also different perspective. For example, we group people of newly diagnosed PLHIV and people living with HIV for like a couple of years, like maybe middle age or like older or younger. Like when they interact with each other, they would learn from each other. Some people told, like one of my clients told me, before they, like previously they joined our service when they newly diagnosed and they received counseling sessions from one of our previous workers. And he didn't join our peer group and workshop for a couple of years, but like he recently came back to our like regular monthly peer group and meeting like people who are newly diagnosed, like who are younger, like with partner, without partner. They have a new perspective from them to like kind of maybe reflect on their own value and like what are the experience. And it did make some positive changes according to him. And we we enjoy empowering like all of our clients and peers that we interact with. We would have like educational anti-stigma workshop that would invite PLHIV to share their experience with university or health, like students and health professionals. And those are different ways of them engaging back into the community to contribute like back to the people who they wanted to assist in. Yeah.
I think services like social services, psychiatrists, psychologists, whatever service they get in touch with, gradually with the treatment that they needed. Maybe psychiatric medication, maybe counseling, motivation interview. I think all these treatments are very useful for some of the cases. The other point I want to make is that sometimes, no matter how much we work, the patient is not ready to receive service or not ready to change. I think one important point is that we don't lose our patients. We don't close our doors. We are always open, and we welcome them to come in, whatever they are ready. And sometimes, very sadly, we have to wait for crisis, I think. Say, for example, there were crises, they will get admitted, and then the doctors need to, like, you have no choice, we have to, like, call your family. In certain situations, I think somehow the crisis will open a door to open the dialogue. And then they will find, oh, my mother is actually very supportive. She's so supportive of my sexuality, everything, no matter, just that if I'm happy and I'm healthy, she's happy with. So I've seen quite a number of cases who are like this, especially when they got admitted or they got to see the doctors. And then some of them actually, their internalized stigma got like opened up, and then they got support from the people they need.
If I can just add and like reinforce what both of you guys said, more so from like my experience in Toronto. Number one is finding community, whether that's within your own family or a community that you kind of reach out to. And the other one is finding meaning. So finding meaning in what you're doing and finding meaning in sort of what you've struggled with and not just struggled with, but are now kind of thriving with. That has been some of the patterns that I've seen.
Thank you. Thank you so much. Thank you. So we are now entering the second part of our mental health discussions. For this part, we'll zoom in and dive deep to inquire the topic more on the sexualized drug use, or what we call chemsex. So I'm so excited to invite our first speaker, Dr. Raina Tang. So Dr. Raina Tang is an assistant professor at the Saw Swee Hock School of Public Health, National University of Singapore, and National University Health System, where he received his PhD. So his topic of today is to share reducing harm and enhancing well-being among people engaged in sexualized drugs. Welcome, Dr. Tang. Dr. Tang fly to Hong Kong. He's so busy. He's been like, oh, I got a conference, and then, you know, being moderator in one conference, and then come here, and then tomorrow he needs to go attend another conference. Thanks so much for your time coming to Hong Kong. Welcome. Yeah.
Thanks so much. Thank you so much. So where do I start? Let's see. I think, firstly, I want to thank the organizers and thank Nida so much for also reaching out. You know, I think it's a real privilege to be here. You know, I wanted to, actually, what was being spoken about this morning resonates a lot with me on like both a research as well as a personal level. And I think it's important to also tie in, you know, like why I'm doing this and to situate my work in my own personal story as well. So, you know, for me, I was diagnosed with HIV 15 years ago. So I've been living with HIV for 15 years, and that was when I was 20 years old. And it was a result of sexualized drug use or chemsex, but also because of a lot of the internalized stigma around living with HIV. You know, I only sought treatment about 2.5 years after I was diagnosed initially. And, you know, I was also engaged in like a very deep cycle of like chemsex. And it ended when I was admitted into rehab when I was 24 years old. And I spent about 1.5 years in Thailand in rehab, because in Singapore, rehab means prison. So, you know, I'm privileged enough not to go to prison in Singapore. But, you know, I had the opportunity to do that in Thailand. And after coming out of it, you know, I think we started to do more ground-up community work to try and support others in the same situation, because, you know, you just didn't find any resources for gay men, you know, in this area back then. You know, we had generic resources from, you know, the Institute of Mental Health in Singapore, or, you know, mental health services, but, you know, we just didn't identify with any of the support groups there, you know, and I think you would see maybe from my slides later that we came from a particular perspective, but, you know, I think throughout my research and my work, both in the community and based on personal experience, we're starting to learn that there are many different angles we can take for, you know, addressing chemsex or sexualized drug use. And I want to apologize. So, like, I use a combination of AI and my own I wouldn't say limited, because I learned Chinese growing up. It's just that my command of the language is not very good. So, you know, there might be some things that may be awkward phrasing or not so good phrasing. Please forgive me. Yeah, so I think I'll focus on like harm reduction for my talk today. I won't cover so much of this because other speakers have talked about the definition of chemsex. You know, one thing that I will say is that in Asia, I think, you know, we still haven't really figured out a common definition. And, you know, I don't know whether we will ever have a common definition because it is so unique to different contexts. And, you know, one thing is that, you know, for Singapore, we have certain combination of drugs, but, you know, for Hong Kong, it might be slightly different based on drug supply chains, you know, which differ from region to region. So, you know, like being able to measure that across different regions is also problematic sometimes. You know, I think I've seen some literature coming out of, let's say, you know, I think Guangzhou, you know, that talks about alcohol being part of chemsex or sexualized drug use. You know, technically, you could kind of label it as that, but we're not really talking about the same thing. You know, so when we compare these things, it might be a little bit difficult. You know, I think the purpose of this slide, and I'm going to breeze through some of them because I know we are also running short on time today, but, you know, this here, you know, shows that based on even just young key populations at risk of HIV, you're already seeing, you know, people start young, you know, like including myself, right? So, you know, like at 18 to 25 years old in Singapore, we ran a cohort study. About 5% of people had already ever used crystal meth in that cohort. You know, in Dhaka, Bangladesh, there's in a cohort of 18 to 24-year-olds, about 6.8% reported ever using meth. You know, in New York, it's about 10%, and they reported engaging in sexualized drug use in the last 6 months. So you can see that, I think for young key populations, this is an emerging issue of a potential concern. Even worse is that among non-MSM or non-gay populations like transgender women or sex workers who are at risk of, the risk of HIV, other STIs associated with chemsex, we don't really know much about that. And the research that has been on trans women, for example, tends to be aggregated together with MSM. So we don't really have that much research focusing on some of these subpopulations that are also vulnerable due to intersectionality and so on. There was a qualitative synthesis, a review done by APCOM on sexualized drug use, including chemsex, and the motivations that they found, I guess, in this region for Asia don't differ too much from that in like the studies of the US and the UK or in Europe. These revolve around, say, enhanced sexual pleasure, freedom and confidence to explore sexual fantasies, and I really like what Odile talked about in terms of the context that we are in, right? I think a lot of these are also a product of, a very stigmatized context that we have grown up in contexts where we are not allowed to be ourselves, where we want to find some form of liberation and emancipation. So I think that makes a lot of sense. And so, issues like pride and empowerment or even beauty and social power should be contextualized in some of these like narratives and contexts that we are growing up in. There are other issues of around using it as a social and sexual lubricant. There's some context where there's a certain community identity and culture attached to being in a chemsex community or sexualized drug use community. But a lot of the work that also I do focuses on using it as a coping mechanism. And I think I also heard terminology like small T trauma and big T trauma. And we can also use a trauma-informed perspective to address chemsex as well. So one thing I want to start from is this idea that when we talk about drugs and chemsex, I think the narrative has always been, we shouldn't talk about it. It's very taboo. Like it's entirely illegal, especially where I come from in Singapore, right? If you fly into Singapore on any plane, it will remind you that there's a death penalty for drugs in Singapore. I think the death penalty applies to drug trafficking, but you don't need to prove that you're drug trafficking. It's you are a presumed trafficker by a large amount, having an amount of drugs above a certain threshold. And that is also problematic because I know people who engage in chemsex who hoard drugs because they are so afraid of, like running out of drugs as well. So, I think these are some issues that we deal with. So coming from this idea of the narrative on the war on drugs, what has this produced in terms of a lot of our public health research for chemsex? I think scholars have, especially critical drug scholars, have talked about this idea of the rush to risk when it comes to public health. So we tend to think about the risk first when we're in public health. And they talk about how, public health has made important contributions to establishing the link between, for example, meth use and sexual risk-taking, but the precise nature of this relationship is often not well defined. We always immediately think of chemsex and risk, chemsex and risk. This creates space for ungrounded assumptions about methamphetamine use to take hold. I think there are other issues that have been raised also, so we also need to acknowledge that there's non-problematic, so-called non-problematic use of substances. That there's some chemsex that, can actually be productive and also to what people think like fun and pleasurable. There's also, we need to reframe the role of drugs as well in sexual behaviors, because if we solely blame drugs for disinhibition and other forms of risk-related sexual behaviors, it actually limits our ways that we understand how to address chemsex or sexualized drug use, by just focusing on that only. And in a related way, we need to move beyond biomedical forms of understanding. The reasons why people use drugs have certain social, political, historical reasons as well. These are unique to each context. And if we want to address the risks associated with chemsex, we need to better understand some of these, the context as well. And so this is something that I've come up with, I guess, as sort of like a framework to think through, what harm reduction might look like based on some of the different narratives of chemsex out there. And this is actually more informed by, what I hope we can approach chemsex as a person-centered kind of approach, meeting people where they are at. And there are different journeys that structure, how we should approach chemsex and addressing harms related to chemsex. One of them is this idea of the chemsex or sexualized drug use journey. I'll share a little bit more. The second one is definitely the context in which sexualized drug use takes place, because how it takes place and where determines what kind of resources you have to address risks for HIV and other STIs, for example. And the third one would be the personal life course. Chemsex journey is just how people started and where they are at in that journey. But we need to think about trauma. We need to think about life experiences. These are also things that people might inform why people use drugs as a coping mechanism, for example. So when we think about the journey, the chemsex journey, actually what we have seen, because I also help run a community, a charity in Singapore where we provide substance use recovery services, and we've seen people come in. Initially what we did was everyone is an addict, because I came from the 12-step group kind of modality, so like when we started our support groups, we said all use is problematic, and everyone who comes in, you can call yourself an addict. And people didn't, a lot of people were turned away, from that because they didn't identify with that. And if we look at the literature also, and we see that, this idea of problematic versus non-problematic in itself tends to be a little bit problematic, because who defines it, and how do people define it? But I think the common ground beneath it is that if we want it to be person-centered, we have to empower people with the knowledge, skills, the social support, and the resources for them to be able to say what is problematic and not problematic. And I think Dr. Lee in the previous panel talked about some people might not be ready to access services, and this is it's kind of related to that as well. This is from Canada, they have a spectrum of drug use that they also promote in their health systems. There are forms of drug use that, there's non-use, there's certain drugs or psychoactive substances that involve beneficial use. But, we think, if we think along the lines of this spectrum, on the other end, it's substance use disorder or addiction. And that's where a lot of our services tend to be focused on. So this is, I just wanted to maybe share this for now. I'll come back to it later. And if we look at this whole problematic versus non-problematic use, there are studies out there that try to research or review the proportion of people who have problematic versus non-problematic use of substances. One caveat here is that these are general population statistics. It might differ from subpopulation to subpopulations, especially for key populations. But what the story that this tells you is that, not all drug use is problematic. And I think being able to identify that will help you reach people where they're at. There are studies also that look at chemsex journeys. So what kind of journeys do people take when they start having chemsex? This idea that you start off with loneliness and emptiness, and then you search for connection, and then after that it becomes problematic, and then the severe health impact. This is actually the kind of journeys that we do see at the center as well. And it reflects a form of coping mechanism and all that. But also this tends to maybe overemphasize that one end of the spectrum, right? Where it's substance use disorder, dependence issues, and all that. So the authors here also say that we shouldn't take this as what will always happen. It does not always evolve this way, but it's also helpful to see where people are at in this journey, so we can make sure that our harm reduction interventions are at the right place. And what kind of themes do we talk about? This might be familiar to a lot of people doing programmatic or social work, or psychological interventions as well. The trans-theoretical model of behavior change, and this is the where people are at. If I'm making a change, is it pre-contemplation? Am I still thinking about it? Am I even before thinking about it? And this is where maybe certain kinds of interventions, like motivational interviewing, and these kinds of interventions that promote or improve motivations for change might be helpful. So if you have a well-made intervention in the community that's fully, evidence-based, but you're not meeting people where they're at, it's also not going to work. Okay, so now that's basically the chemsex journey, right? These are all the different considerations that you need to take. Now let's look at the context in which chemsex takes place to make sure that we are reducing harms in that context. So this is a study, I think, published by colleagues in Taiwan and Australia in the Lancet HIV, which looks at harm reduction for chemsex. And they break it down to a very event-based approach. And basically they're saying that when you have chemsex, there are these risks that you need to take care of. One of them is HIV, one of them is the sexual risk, and one of them is related to drugs. And there are all these different things that you can do, to address these things individually, but also these are the things that you need to think about to address, all these reduce harms in these contexts holistically as well. So I think it helps. It's actually quite helpful when you're thinking about harm reduction interventions, for people who are engaging in chemsex, to help them make sure that they reduce the harms, all these types of harms that are typically associated with it. One thing about context also is that we've looked at a lot of qualitative research as well, and we noticed that the way that chemsex takes place from one place to another is quite different. And I think being able to know what are the different rituals, how do people go online, what kind of words do they use, like how do people meet, where do people meet, what happens, in Singapore when people have like chem fun or chemsex, like there's also a bit of like card games playing, and like a lot of these like social things, right? Which are also opportunities to inject certain kinds of harm reduction, like messaging. We haven't been so creative yet, but I think those are all important, right? Because it tells you a little bit more about what people value in these spaces as well, and what access to harm reduction resources that they have. And the third one, looking at life histories. This is some research that we've done at the Greenhouse, which is the community group that I'm with. And we looked at how trauma underpins a lot of chemsex in our clients as well. So like basically there's sexualized drug use or chemsex, but among our clients we note that a lot of this is underpinned by psychosocial distress, sexual shame around their sexual orientation, social anxiety, low self-esteem, loneliness, and then we wanted to dig further, right? Why are our clients facing these issues in such large numbers, huge numbers of like reported forms of like adverse childhood experiences and stuff. And then we realized that a lot of their precipitants here are underpinned by forms of trauma, especially small t trauma. So folks who have undergone racism, HIV-related stigma, sexual violence, neglect, internalized homophobia, and all that, tend to present with a lot more of these precipitants. And when we look at the context that we are in, actually in Singapore, people grew up in this context where being gay was criminal, right? I think it was only 2 years ago that we repealed Section 377A. It was actually just like 1 month ago we now don't require people with an undetectable viral load to disclose their HIV status, which is a great advancement in our legal policies. So there has been a lot of discrimination and stigma associated with being gay, living HIV, and all that. And these all underpin all these things, which then weighs down on the idea of sexualized drug use or drug dependence. So I guess to sum up that harm reduction part, like if we're thinking about harm reduction and we look at all these different complex issues around chemsex, I think understanding where they are at in their journey of chemsex, understanding if it's dependence or substance use disorder, like at which stage of change that they are at, what kind of life histories do they have, what kind of traumas do they have, and what are the different cultural practices associated with chemsex. If we are able to understand all these things holistically, I think we are able to better develop harm reduction interventions for people where they are at. And this is something that is sort of like me putting together all these things that we have presented so far. So, if we wanted to make it maybe a little bit more simplified, we could think about, where people are at in terms of their type of use. There's people who don't use, people who use and they feel that it's been beneficial to them. It helps them connect. It helps them gain more pleasure. There are people who use it, but they expose themselves to risks. There are people who use it and they're dependent on it. I think the approach should be different. And like if we think about people who don't use it, I think it's still important to reach out to them, right? Because a survey that we did in Singapore, basically 50% of our MSM or the gay men in Singapore have ever tried so-called illicit substances. So it's very safe to say that 1 in 2 people will encounter substances in their life. It's just that what kind of context you're going to be in. So having early education programs for young key populations is important because we have to really grapple with this idea that you will encounter drugs. We cannot not talk about it or until after you've encountered it. So what kind of early education programs do we need? And those who are in that space of, I'm kind of using it like once a year. I go to these circuit parties, like in Thailand or Bangkok, engage in a little bit of chem fun, chem sex. It's been very fun for me. I use PrEP, I use, like DoxyPEP, whatever, very empowered people. I think it's also safe to assume that some of them might run into issues time to time. And so being able to still have harm reduction services for them is still important, like the one that we saw in the Lancet HIV Venn diagram, right? Reminding people, don't mix this with that. I've got some examples in the next couple of slides. But when you start to see higher levels of risk associated with use, I think that's where we need to maybe have more interventions. And I'm a bit more familiar with those who are on the right end of the spectrum because that's where our services are. And we do like peer support systems. We are more community-based. We're an anonymous clinic. So I wouldn't call it a clinic. We're an anonymous service, with peer navigators, peer supporters, counselors involved. And so that's where we try and customize care because we really need to get people involved with psychiatrists, psychologists, long-term support groups. We link people up with support groups like Smart Recovery, Narcotics Anonymous, things like that. So I think that's where we need a little bit more intensive programs. So just some examples, I'll breeze through this. So like early education programs, to focus on, what are these common drugs you might encounter, where to find resources if you need them, and also maybe teaching people how to support others. When we give talks like that, a lot of people ask during the Q&A, if I know someone who's engaging in chemsex, like how do I talk to that person? These are all things that we can equip people with. I've seen this being posted. So I think our local NGO posted this once right before like the circuit party season, and they got into a little bit of trouble around it. But this is like a chart that shows you what you should not mix. GHB should not be mixed with alcohol. And all these things. And I think it's in response to the fact that on average every year, we hear like maybe one person dying, from just mixing the wrong things, right? So I think that's an important thing to save lives. Less in Asia, we actually see, so this is the imagination when you think about harm reduction, right? We often think that harm reduction involves like safe injecting spaces and all that, but it doesn't have to be. In Asia, where it's still a lot more punitive context, this is something that we might encounter less. But I've seen some of these interventions in the UK where they use like Grindr, where they know people are they are hooking up, with like chem fun or chem sex, and then they provide information there. That's something that you could see as venue-based intervention as well, because we're just not only looking at in-person venues, but online venues too. These are some brief interventions. I won't go into too much detail, but like if you are in a place where you are more likely to see someone with a heightened risk or heightened chance of experiencing harm, in a PrEP clinic, for example, you might be able to have some brief interventions based on cognitive behavioral therapy, motivational interviewing. They've done this for alcohol-related disorders. I haven't seen one for like chemsex though, so definitely an area to do some interventions in. There's also customized care, which I talked about, which we kind of do as peer navigators in the community. So we make sure that, okay, if you come in and do intake, first we are going to make sure that your HIV STI testing is done, link you up with someone who can provide PrEP or PEP. If you need like medical advice, we can actually bring you to a psychiatrist. We don't actually provide those services, but we have a 6-month peer supporter that follows someone through this whole like process for 6 months as sort of like a para-counselor. And this is the community group that we have. I won't go into details, but you can find us online, the Greenhouse. And these are all our volunteers and our board. So we basically, our program is based on counseling, peer support, 6 months peer support, 16 free sessions of counseling. We do like horticulture therapy and all that. And it's all entirely free for people because we also, the counselors are also free to us because we are a training site for them. So we partner with schools to do practicum training. We just pay our volunteer clinical supervisor. But yeah, if you want to find out more, you can talk to me during the break or during the Q&A. We also have a guide for how to deal with law enforcement, because I think the law enforcement in Singapore is not very friendly. And harm reduction to me is always about, the law can also harm you. So how do you stay safe from the law? It's quite ironic, but it's the fact. Because if you get incarcerated, I constantly have people I know in jail. And I think it's quite tragic, especially when a lot of them are facing issues of homophobia and all that, right? And if you are caught consuming, it's like 1 year in prison in Singapore, and their life basically just crumbles after that. So you're doing more harm than good, right? So I think this is a guide that we decided to do for people on how to deal with law enforcement in different situations. So I won't go into my key takeaway messages, but I'm happy to share the slides around if you want a copy of the slides. But yeah, I think that's all I have for today. Thank you.
Thank you so much, Dr. Tang. I learned a lot. We often talk about harm reduction, but he really gave us a pictures how to operationalize, like into different framework and steps. Yeah. So now we're going to the second part of our mental health sections. It's focusing on the chem-sex the issues. So in this sections, it will be in Cantonese because we're going to explore the narrative approaches working with Canton community in our city. 所以我哋下一個嘅 section 咧係會用廣東話嚟進行嘅。咁咧joining us today is Professor Shelley Hong from the Hong Kong Baptist University as well as clinical psychologist Dr. Barry Tam. And this section will be facilitated by Kensley Choi, our assistant manager of testing and counselling team at AIDS Concern. 咁我就請阿 Kensley 上台就介紹埋我哋兩位嘅嘉賓啦，好冇啊？唔該晒 Kensley。
都可以上嚟就座先嘅，隨便。係啦，咁我都即係好榮幸，今日係即係上午嘅 session， 小心。上午嘅 session 嘅最後一節啦，咁亦都係唯一一節今日係講廣東話嘅一節嚟嘅，係啦。咁就都有少少 recap 啦，即係我都即係聽咗成個上晝嘅時候，我都會不斷去諗，就係其實啲乜嘢都會係拉到落嚟，我哋呢節可以論一論嘅咧。咁我會頭先會寫低嘅就可能 Crystal Lee 都有講到，我喺面對 Canton 嘅時候離開同埋進入好多拉扯喺中間，我哋需要去面對到嘅。咁或者好似Gordon Wong 都會有提到 internal stigma， 即係我哋可能面對嘅唔單止係一個 stigma，MSM 可能係 PHIV 或者都有玩 Canton 嘅一個情況，即係都唔係一啲社會認可嘅一啲 identity 啦。咁呢啲都係即係我哋都要去面對嘅一啲處境咁樣咯。咁我哋即係諗到落嚟嘅時候，我哋就會諗就係都會去一個即係major 呢個主流論述去睇呢件事嘅時候，好似好無能為力咁樣。但係當我哋即係再睇多啲，將呢件事擺喺社會上面嘅時候，又係咪真係咁無能為力呢？咁所以我相信即係呢個係一個原因，點解我哋擺咗narrative therapy 係咗呢個 session 做一個討論嘅。咁就都介紹多少兩位即係我哋嘅今日嘅 guest speaker 先啦，係啦。咁就洪樹聯教授啦，咁而家就係浸會大學度工作嘅。咁係呢個社會工作實踐及精神健康中心嘅中心主任啦，係咯。咁主要嘅研究項目都有呢個婦女同家庭性別暴力，跟住小組工作同埋社區發展啦。咁最重要就係都有敘事治療嘅一個部分啦。咁喺幾年前Professor Hong 都同呢個 Project Hero 做咗研究，咁就係關於呢個敘事治療同埋於呢個 Canton 社群嘅應用同埋實踐嘅。陣間洪教授就會 share 多啲㗎啦，係啦。咁另外就 Dr. Barry Tam 啦，咁佢就係個臨床心理學家嚟嘅，咁就係而家喺一個本地嘅醫院度工作啦。咁佢嘅服務對象都包括即係 HIV 感染者啦。咁大家可能即係坐咗成個上晝嘅 session 都會知道，其實HIV 感染同 Canton 都有一個都叫做密不可分嘅關係喺入面啦。咁所以喺佢嘅日常嘅工作裏面都會接觸到可能即係HIV 感染者加有 Canton 呢個hobbies 嘅習慣嘅一個服務使用者咁樣咯。咁所以咧，我哋就喺呢個 combination 裏面咧，陣間就會Dr. Tan 就會再講多啲佢可能臨床工作裏面嘅一啲遇到一啲個案嘅一啲情況啊，或者佢哋一啲諗法咁樣嘅，係啦。咁我都又介紹下自己啦，我係 Kensley 啦。咁好似 Lida 頭先所講，我就係呢個testing and counselling team 嘅一個 assistant manager 啦，暫時咁樣係啦。咁就點解會揾我做 moderator？ 咁我諗係我自己對呢個題目都有啲熟悉啦，咁樣咯，係啦。咁亦都工作咗好多年，亦都會喺嗰個工作上面會遇到呢個社群嘅一啲人士啊，或者會接收到唔同面向嘅一啲 information 左右咁樣啦。係啦，咁所以都好開心，今日就有呢個機會可以同兩個大師交流一下啦，咁樣。 係啦，咁就都講咗一大段嘢啦，咁都想拉翻即係兩位啦，因為我都會有聽到有啲人會講呢個narrative approach 係一個即係敘事治療嘅一個名稱，或者佢會講就係叫做敘事實踐。咁我都想問翻Shirley 係咪有咁叫你？
我經常強調佢叫我 Shirley 得㗎。
即係呢個叫法上邊有冇啲咩唔同啊？或者你自己取向於點樣去叫呢一樣嘢咁樣
？OK， 其實 Kensley 太謙虛啦。其實佢唔係即係有認識，佢係好有深入地認識，係啦。因為佢都係做咗敘事治療好耐嘅，係啦。咁咧就我自己嘅理解啦，因為都冇乜嘢學術文章啊睇到，即係講 narrative therapy 同 narrative practice 嗰個嘅即係起來源或者個分別咁樣樣。咁我自己嘅理解嚟嘅啫嚇，即係大家可以一齊去諗下傾下。咁咧就係我嘅認識裏邊咧就係 Michael White 啦，大家都聽過啦，佢就係敘事治療嘅一個即係創始人啦嚇。咁佢本身係一個社工嚟嘅。咁同埋佢都係一個 family therapist 嚟嘅，咁所以敘事治療嘅開始嘅時候咧，其實係由家庭治療嗰個系統嗰度走出嚟嘅，即係佢係喺佢本身係一個家庭治療即係嘅人啦，咁所以佢喺嗰度去一路發展一啲新嘅諗法。咁當然佢喺嗰個系統度走出嚟咧，但係其實佢都係顛覆緊家庭治療嗰個諗法，傳統即係家庭治療嘅諗法。咁所以其實我自己聽一路學佢都係一個 therapy 嚟嘅。咁但係大家又都好明白咧，就係話對 therapy 嗰個諗法咧，其實喺傳統一路以嚟咧，其實都相當狹窄嘅。即係我哋對家庭治療嘅理解或者個人治療嘅理解咧，一般都會係諗即係有個專家，然之後坐低就同一個即係受服務嘅接受者咁，然之後我哋要了解佢個問題，然之後我哋俾好多嘅 advice 佢，然之後睇下點樣幫到佢咁樣樣係啦。咁個 therapist 又好叻嘅，咁係咪？即係我哋又知道好多嘢嘅咁樣樣。咁同埋都係基本上可能會個焦點擺咗喺個人嗰度，即係甚至乎可能一啲內在嘅嗰個人嘅內在嘅一啲嘅問題啊、欠缺啊，或者佢一啲嘅諗法有啲咩唔 OK 啊咁樣。咁呢個係傳統我哋對治療嘅一個比較即係窄嘅理解啦。咁去到敘事治療咧，因為其實佢嗰個背後嗰啲諗法咧，或者我哋成日講個哲學咧。其實就係話佢係睇多啲，其實即係人嘅問題唔係佢自己喺個內在度產生出嚟嘅好多時，而係經過社會好多嘅即係文化上高嘅影響啦，或者好多即係制度嘅影響啦，好多嘅影響之下咧，令到嗰啲問題係咁樣去呈現嘅。咁所以其實敘事治療係好強調咧，就係話即係一個即係文化嘅建構啦嚇，一個社會嘅建構啦，對於問題，咁佢哋會講多啲係即係個社群點樣去面對呢樣嘢，或者我哋集體一齊點樣去面對呢樣嘢。嗱喺呢個環節咧，你就會見到佢超越咗即係傳統，或者佢挑戰緊傳統所謂治療嗰個嘅理解啦，嗰個概念啦。咁所以我哋開始就用實踐呢個名詞，因為呢實踐係闊啲啦嚇，即係 suppose 我哋係你個人又得，家庭又得。群體又得係啦，咁亦都可能即係跳咗出去，即係多少少唔係傳統嗰種對治療嘅理解啦。咁但係今天我哋兩個名詞都仲用緊嘅，即係你會見到我哋又用 therapy 又用 practice。咁如果你問我咧，都係個人理解我就覺得咧，我哋仍然覺得佢係一個 therapy 嚟嘅。係啦，但係佢唔係一個我哋一般理解嗰種 therapy， 但係佢仍然係一個 therapy。而我覺得好重要，仍然叫佢 therapy 嘅意思係好 political 嘅，好政治性嘅，就係我哋要 speak 個 therapy community。即係好多 therapist 佢如果你話俾佢聽呢個唔係 therapy 嘅話咧，佢完全唔會有興趣去知道你係做緊乜嘢，或者你挑戰緊啲乜嘢。所以我哋係要喺翻即係治療嗰個系統裏面嘅世界裏邊去做一啲影響嘅時候，即係我會仍然即係會我哋仍然會叫佢做 therapy。都幾 political 嘅考慮，如果你問我。咁但係同時間我哋又會叫佢做 practice， 因為佢真係超越咗即係我哋好狹窄嘅一個對治療嘅理解咁樣嚇。
明白，即係 我都係走出輔導室以外，都有社區層面都有啲 intervention 嘅一個 approach 啦。但係要翻返去治療嗰個界別嘅時候，我哋有一次有少少無可奈何地，我哋要用到即係治療呢個字眼。咁我都會想問下 Barry，你都會喺個治療嘅系統入面㗎嘛？咁你會點樣 prefer？
好治療嘅一個系統添，即係入到嚟係啦，即係嗰個樣都嗰間房完全都唔似係唔治療啦，係咪？咁但係我有時覺得係即係除咗敘事治療或者敘事實踐，我覺得係敘事嘅哲學嚟嘅。即係我估係我哋點樣睇事物嗰個態度，其實好反映到我哋點樣去用乜嘢嘅方法，用乜嘢嘅角度去同我翻嚟見我哋嘅人去傾偈嘅。咁所以我估嗰個哲學係即係好似頭先 Shirley 咁講，係佢係挑戰緊個傳統或者顛覆緊個傳統。我傳統地我臨床有心理，梗係成日就話人有病呢樣病嗰樣病咁樣。咁即係病人會同我講話其實我唔想再見到科咯，即係已經夠多病㗎啦咁。咁我即係如果我仲係用一個病理嘅角度咧，就真係講客嘅，即係冇人想翻嚟見我。但係如果帶住一個即係敘事嘅哲學去睇嘅時候，即係會令到佢哋翻嚟見我嘅時候，會覺得原來係傾一啲關於佢嘅事情，唔係傾關於我想傾嘅佢有咩症狀、有咩病理。對於翻嚟見我嘅人咧，會舒服好多。所以我有時覺得係嗰個哲學嚟嘅，係一個即係我哋可唔可以喺睇佢嗰個所謂嘅問題裏邊，我可唔可以睇到一啲另外一啲嘅方法去理解呢件事咧？咁樣
明白。咁頭先兩位都各自有提到顛覆一個即係以前一個諗法啦，即係唔係話我由一個 counselor 主導，或者我一個治療師作為主導去評定人哋我有冇病，你需要幫助，我點樣去 diagnose 你咁樣啦。咁我都想請 Shirley 可能 share 多啲，其實NT 或者 MP 啦咁嗰個 concept 啊，或者論述會係點樣樣？可唔可以講多少少？因為未必個個都知道。
同埋我覺得係特別適用於特別好地，亦能夠應用於好似 Barry 講，就係當我哋做一啲cam 分嘅一啲朋友啦或者係HIV 啦，或者係即係同志嘅群體啦咁樣樣。咁我覺得佢個理念好特別嘅地方咧，就係通常呢啲朋友嚟到我哋嘅時候咧，其實佢哋都會係已經好似頭先 Barry 講，見過好多專家㗎啦。咁然之後佢哋自己都內化咗，即係其實嗰啲問題係我嘅問題，點解咁耐都戒唔甩咧？明明知道嗰樣嘢唔好，你又點解停唔到自己呢？呢啲都肯定係你有問題㗎啦，即係唔係其他人唔幫你，或者即係而係你自己要一個好大嘅即係責任，係你自己搞唔掂自己咁樣。咁嗰種 self stigma 同埋嗰種即係內化自己嗰種問題係好強好強。咁敘事治療有一個好嘅地方咧，就係話即係佢覺得人唔等於個問題啊嘛。個問題係問題，人唔等於問題嘅時候咧，佢就將個問題同個人分開咗，以至於嗰個人咧可以比較客觀地或者一個距離地去睇，其實嗰啲問題係點樣出現嘅咧？即係最開初佢去接觸 cam 分，去接觸 drugs 嘅時候，好多故仔點解會開始呢樣嘢咧？嗰個背景係點樣樣咧？佢碰到啲乜嘢問題喺嗰個乜嘢嘅處境裏邊？我哋都好了解，即係我諗今天大家一路聽好多就係同志嘅群體，如果佢係 take 埋 drugs 係咪？然之後佢再有埋 HIV， 即係我哋成日話佢都唔知幾多層嘅即係標籤嚟嘅，係嘛？即係佢喺一個咁樣嘅處境裏邊，其實佢好難去覺得自己仲有辦法，仲有能力。仲有希望係啦，咁敘事就話俾佢聽，其實唔係，即係你個問題嘅出現有一個背景喺度，有一個 context 喺度嗰個唔係淨係你自己有好多問題，你自己嘅完全係病態咁，所以你進入一個咁樣嘅狀況。咁所以我哋將問題外化嗰個做法，其實就係講緊呢樣嘢啦。咁另外就係嗰個我哋講好多係社會建構嘅理論啦。同埋就係後結構主義嘅理論啦，咁其實都係講緊就係話，即係頭先講問題係好多嘅因素喺裏邊，包括我哋成個社會嘅文化，我哋社會嘅一啲嘅做法，一啲 practice， 其實都係製造緊呢啲問題嘅咁樣。咁另外就仲有一個好嘅地方，我覺得即係敘事嘅理念咧，佢就話佢唔會睇一個人係完全冇能力處理佢嘅問題。即係佢唔係坐喺度等死嘅，講得衰啲，唔係冇一個人會坐喺度讓個問題完全控制佢，然之後佢一啲嘢都不能夠 抵抗到。咁敘事就好重視，就喺我哋叫重寫生命故事嘅時候，我哋就去揾翻其實每一個人一定有好多嘅能力，有好多嘅知識技巧，去讓佢一路點樣去處理呢啲嘅問題，或者減少呢啲問題對佢嘅影響。而更加緊要喺敘事裏邊咧，佢就係講一個人嗰個身份認同。即係嗰個 identity 啊，嚇！即係你見到，即係大家一定會想象到呢啲朋友佢嗰個 identity 係一個 problem 嘅 identity， 即係充滿住問題，或者個 failure 嘅 identity， 一個失敗嘅身份。我從來都冇成功地離開過 camp。即呢個一個好 spoiled 嘅 identity， 其實喺敘事裏邊，佢哋就會透過譬如重寫生命故事或者好多其他嘅方法，讓佢睇到，喂，你唔係乜嘢能力都冇，你唔係冇努力去應對你嘅問題，你唔係冇嘢改變過。即係呢份問題最嚴重嘅時候，同你現在可能已經係有一個好大嘅分別喺裏邊，係啦。咁所以我自己覺得真係好適合，即係敘事嘅諗法係好適合，即係喺呢啲群體裏邊去用咯。嚇，都
明白嘅，即係會睇到就係即係唔好將個問題歸咎於個人身上面，都嘗試去外化睇翻呢一件事，再去揀一啲即係自己嘅一啲 unique outcome 擺翻落自己 story 度。咁我記得我之前同Barry 去 Zoom 嘅時候都有提及嘅，我點樣寫傳記啊？點樣去幫點樣可以協助嗰個人去 pick 一啲佢嘅story 一啲最 sparkling moment 抌入擺翻落去。我都想你 share 多啲呢方面嘅一啲情況，即係當你即係入到呢個輔導室入面，即係都想同嗰個個案去 go through 呢個 session 嗰個 journey 嘅時候，你自己會係點嘅取態嘅咧？咁樣
我都好多時即係病人翻嚟，梗係見我嘅時候，就梗係自動咧就已經喺度即係自首啦，或者嗰啲即係告解啦，咁啊將自己過往犯嘅事就要寫晒出嚟啦，講晒出嚟啊咁。咁但係喺嗰個時間，其實我有一個好秘密嘅工作，就偷雞咁樣做緊嘅。其實我就要喺度剪裁緊一啲有用嘅材料，係愛嚟準備我之後要同佢即係用一個 narrative 嘅方法去傾嘅。即係例如一啲對於佢嚟講好重要嘅人，或者有啲乜嘢佢好似堅持住，或者佢永遠都唔肯 let go 啊，或者佢好即係嗰啲事情好似睇落去有啲脈絡係睇落去好似唔係好明顯，但係又好似有啲嘢佢好似一致地會做緊嘅。咁嗰啲我可能會有個好奇心，就係之後可能喺嗰個嘅治療裏邊嘅時候，即係所謂嘅治療裏邊咧，我哋就會做到咁。咁有時我估係啦，我要擺低個專家身份啦，即係所以就叫佢哋叫我名嘅。咁所以咧嗌我 Doctor Tam 咧，佢哋唔知邊個嘅，但係講 Barry 咧，佢哋知係邊個啦咁。咁都係令到喺房裏邊嗰個嘅權力咧冇咁唔一樣。如果嗌我 Doctor 乜 Doctor 乜，即係我話乜就乜啦咁佢真係嚟自首啊！我變咗神父啊咁但係就唔係嗰件事嚟嘅。但係如果當佢真係嗌我名嘅時候咧，大家一齊去共建呢件事，就令到我哋去做即係重寫翻去生命故事。頭先 Shirley 講嘅嗰個部分咧，就會易好多。咁有時我哋會形容嗰部分咧，我係陪佢哋一齊去寫翻佢哋人生嗰個嘅傳記去自傳。我有時會比喻我係個記者嚟嘅啫，其實我幫手去記錄低啲嘢，而佢好多時因為翻嚟講古仔俾我聽嘅人咧，佢都會講肉眼世界見到嘅嘢啊，發生咗咩事喺佢身上邊啊，跟住佢又點樣啊，嗰啲嘢都係佢對眼見到，但係好多關於佢內心世界，即係呢啲肉眼世界發生嘅事點樣影響到佢內心世界嘅諗法啦、感受啦，佢有啲乜嘢想去做啦，佢盼望啦、佢嘅期望啦，或者佢一啲嘅夢想啦，佢都未必有機會講，但係我就可能會透過我作為一個記者幫佢去筆錄嘅時候咧，我就可以去提出呢啲問題，用我嘅好奇心幫佢豐富翻啲資料，令到佢寫出嚟個古仔再唔係我係一個我上癮咯、導遊咯、我就感染咗咯、我就基嘅咯咁佢就可以寫翻另一啲嘅古仔出嚟，其實係講緊佢佢可能聽落去都可能同你同我嘅古仔係差唔多嘅。都有一啲好令到人感動，佢有佢好獨特嘅一啲嘅身份嘅啲古仔出嚟，咁所以有時呢個就會係我做嘢上面嗰個角度。
明白，都好豐富啦。即係作為一個 治療師，其實又唔係治療師喎，都會係一個作者或者筆錄嘅人員去記錄翻即係回顧翻佢過去嘅時候一啲可能即係已經被人遺忘咗，但係其實都好重要嘅一啲經歷擺咗喺度，再去重新拾翻自己嗰個 preferred 嘅即係個想要嘅身份，再點樣去睇翻將來啊，帶來一啲希望啊，點樣再行以後嗰條路啊等等。咁我都有啲問題寫咗嘅，所以我都要問埋先嘅，係啦。咁你哋覺得啦，敘事治療或者敘事實踐啦，適唔適合 apply 喺即係 Canton 呢個 community 啦？咁同埋有冇一啲個案你都印象深刻，其實都會想可以喺度可以分享到嘅咁樣係啦。表先 Shirley 先。
適唔適合咧？我頭先即係連帶都講埋，係啊，即係介紹嗰啲基本嘅諗法，即係概念嘅時候，即係連帶都講話點解佢會咁特別適合，即係我哋叫一啲叫小眾嘅群體，因為小眾嘅群體喺個大社會裏邊係好難去講佢哋嘅故仔嚇，即係冇人有興趣聽，或者講已經引嚟好多嘅即係 judgment 判斷，咁所以其實係好困難嘅，即係但係我諗敘事實踐係俾佢哋有一個空間，我哋係即係我哋嘅責任係即係製造一個空間，讓佢哋有機會去講佢哋嘅故仔，唔使喺好大嘅壓力底下被批判嘅狀況底下去講佢哋嘅狀況，然之後即係佢哋都其實有好多嘅意見嘅，對於我哋而家嗰啲即係社會服務啊，對於我哋嘅社會制度啊，其實佢哋好多意見。咁譬如乜嘢令到一位男同性戀者佢覺得咁難去建立親密關係呢？點解要用呢啲方法，某一啲嘅方法去揾 partners 咧？咁其實呢個唔係佢淨係講緊一個個人嘅選擇嚟，而係喺我哋成個社會裏邊點樣去對待呢一啲嘅群體。我哋俾咗一啲乜嘢嘅限制，俾咗一啲乜嘢嘅即係壓力俾佢哋，令到佢哋即係只可以喺一啲好有限嘅空間裏邊去其實做緊一啲我哋覺得每一個人都應該有權或者有權利應該可以享受嘅一啲嘅即係與人相交或者去建立關係嘅一啲嘅即係空間咧咁樣。咁我諗敘事治療係好好嘅，因為我自己過去嘅經驗同 Barry 有啲唔同嘅。Barry 就係個人多啲嘅，我自己係做即係社群敘事實踐多啲 collective narrative practice。咁我做法咧就係擺喺小組或者擺喺個社區裏邊去做嘅。咁個效果係好唔一樣嘅，就係話即係其實佢哋自己嗰種故事嘅分享一齊去重寫一個故仔，而重寫嘅故仔唔係淨係個人嘅故仔，都係呢個群體嘅故仔。咁所以我哋好多時除咗話講個人嘅故事，然之後每一個人再重新點樣睇自己嘅身份之外咧，我哋仲會做多一樣嘢，就係話你點樣睇呢個社群。即係我哋有一班人而家喺呢度，透過我哋呢啲嘅故事嘅分享，睇到我哋其實好有能力。我哋對關係，對我哋喺呢個社會裏邊嘅角色，我哋對好多嘢我哋都有希望嘅，我哋有憧憬嘅。帶住呢啲嘢，我哋會想點樣去影響嗰個即係世界。即嗰個就喺一個集體嗰個層面裏邊，就能夠即係做到呢個嘅效果嚇。咁所以即係我真心地覺得係好適合嘅。
明白，即係個人有陣時候，你諗即係個人嘅力量可能比較單薄啦。我哋透過集體敘事嘅時候，亦都可以去再加強翻我哋一啲即係力量去面對同一個問題啦。我哋可能咁樣去諗呢件事。咁可能就落翻個人嘅時候，我喺輔導室裏面有冇啲個案你都可以分享一下？
都有嘅，即係我唔可以講得太仔細咧，但係即係都令我諗起有一個個案係即係佢開頭翻嚟揾我嘅時候有 camp 啦，咁當然亦都係感染咗啦。咁開初佢其實做一份佢唔係太喜歡嘅工作，咁佢又喺嗰份工作上面即係都令到佢有情緒好差啊，每日真係到要翻工嘅時候會 panic attack 啊咁樣，咁結果跟住變咗做 long term sick leave 啦咁樣，咁但係喺裏邊即係佢好努力試過好多次想嘗試去翻工，但係都係翻唔到，但係佢又 keep 住呢份工，我都有啲諗，咦，其實都幾特別，我都拖咗好耐，但係佢仍然好似好想堅持又翻呢份工，但係佢又翻唔到。我反而就好奇，其實如果唔俾呢份工鎖住嘅話，佢會做啲乜嘢咁？咁佢就講起，其實佢想做某一個助人嘅行業，但係礙於佢某啲嘅原因，令到佢覺得有啲嘢佢怕嘅，咁佢覺得佢會做唔到嘅。 咁啊唔緊要啦，後嚟咧就疫情開始啦，咁啊佢又俾人肥雞餐咗啦，咁啊攞住筆錢就唔知可以做乜，咁佢一日突然間諗啊，不如試下讀啲課程，試下會唔會可以做到啲其他嘅助人嘅行業啦咁樣，咁跟住又俾佢竟然即係都揾得到，咁但係即係佢讀到，然後跟住再揾到一份即係初階嘅工作，咁佢發覺咦原來佢開初擔心佢做唔到助人行業嘅一個恐懼，原來係唔存在嘅咁，甚至乎喺裏邊佢講咗一個古仔俾我聽。佢點樣陪一個佢幫嘅人？嗰個病人都即係佢幫嘅一個病人係已經係末期嘅即係病㗎啦咁每日都淨係攤喺張床就唔喐咁樣。咁佢每日就去撩佢講嘢，然後就嘗試氹佢落床行咁樣。咁佢氹咗幾日，跟住個病人終於頂佢唔順，就陪佢行下啦咁。咁跟住越嚟越行得多，跟住佢哋兩個其實亦都每次行路嘅時候會傾下偈。佢喺個過程裏邊其實雖然好似話聽呢個故仔佢幫緊個病人，其實呢個關係呢個經歷都幫緊佢，令到佢重塑咗一個新嘅，即係喺呢個新嘅關係裏邊，佢揾到一個新嘅身份出嚟。原來佢都有能力幫人嘅，原來佢都可以成為一個即係助人嘅人嘅咁。咁喺呢一度就開展咗佢一個新嘅一個古仔。咁之後佢就真係成功成為一個即係助人嘅行業嘅人員咯。咁樣咁係呢個都係我諗起即係可以話 individual 嘅工作上面會有嘅即係 narrative 可以幫到嘅嘢。
明白，不過呢個都 remind 咗少少嘢，就係有陣時我哋會諗就個人嚟到輔導室去見我哋嘅時候，好似嗰個治療師去幫緊嗰個人，其實有陣時我哋就會諗，可能嗰個 story 帶到幫到好多 reflection、好多 impact 喺入面都唔定嘅時候，所以有陣時就係一個互動、一個交流嘅狀態咁樣咯。咁我哋時間係有限，同埋我諗大家都肚餓啦，咁所以我哋 wrap up 咗少少就係有冇一個即係 take home message 會俾到大家，要重中之重要記住，呢個係好重要㗎。你嚟過呢度，你就要有粒種子擺咗你腦度啊！有冇呢個 take home message 俾到大家咧？
佢其實我哋傾偈嘅時候講多咗好多，不過點解突然間要我講一個重中之重咧？就大家唔識講添。咁咧就我諗都係我諗敘事實踐或者敘事治療真係影響得我自己好緊要，就係喺過去10幾20年，我諗我即唔係淨係一個工作嘅方法，而係真係影響埋我自己一個人，即係作為一個人嗰個價值觀或者我自己個世界觀係點樣樣。我覺得即係會好希望同大家分享嘅就係話其實我哋自己唔係好叻嘅，即係好多嘢我哋都係透過聽好多嘅故仔，即係願意好多人願意同我哋分享佢嘅故仔。呢個係一個優越嚟嘅，我自己覺得即係。但係我自己會係經常做一樣嘢，而我知道好多人好多專家都係好困難去做一樣嘢咧。我係會向我嘅服務對象，我係會向同我分享佢故仔嘅朋友去acknowledge， 即係去確認其實佢對我生命嘅貢獻喺邊度。即係我覺得我哋真係喺呢度，我哋喺敘事裏邊，佢有一個概念就係話個 self 係 relational 嘅，即係每一個人個自己係一個身份係一個關係性嘅，即係你唔係坐喺度諗自己係一個點樣嘅人，你係喺個相交裏邊，喺個互動裏邊去建立你自己嘅身份。咁所以如果你有呢個諗法嘅時候，我哋同佢哋大家一齊或者大家一齊去 interact 嘅時候，其實咪互相建立緊嗰個身份咯。咁所以佢有一個概念咧，就係我哋嘅 self 係即係 mutually constitutive 嘅，即係我中有你，你又中有我，即係你影響緊我係點睇自己一個點樣，我影響緊你係一個點樣嘅人。咁所以我自己喺我自己嘅工作裏邊咧，我係不放棄任何機會，或者我係好願意去向我嘅所謂 client， 即係去話俾佢聽，其實你都 contribute 緊 to 我嘅生命，或者對我嘅工作嚇。呢樣嘢我係好願意同大家分享嘅，係啦。
我好簡單嘅啫，就係我覺得人生係本傳記嚟嘅。咁經歷咧，我哋改變唔到，但係我哋可以選擇寫啲乜嘢落去呢本傳記度。咁我就希望即係大家同工可以幫翻嚟見我哋嘅人，去做翻佢哋自己本傳記嘅主筆咯。
多謝晒兩位。我哋仲有 Q&A 嘅，
大家會唔會太肚餓？
會太肚餓。好快，我哋 I think we can still have like 5 minutes like Q&A section. So I would like to invite Dr. Tan 上埋嚟。我幫你。
係喎，仲有一個
一齊坐啊！一齊。 Okay. 有個麥。我驚你哋都好多互相有問題，我 feel 到會可能。Anyway, so any questions? We have like 5 minutes, and then yeah. So take your time. Any questions?
Yes. 大家都肚餓啦，可能。
我問一條得唔得？
可以啊，梗係可以。
我好中意呢個 session，因為我係好 believe in narrative approach 嘅。當然喺香港個環境咧，最大嘅問題就係、即係經常你同啲醫護人員講，就係會覺得我哋冇時間咯，去做呢啲咁詳細嘅工作。narrative approach 你要去真係好有耐性。去聽人哋嘅 story， 再去 discern 究竟呢個 story 裏邊有一啲乜嘢嘅含義喺裏邊啊，佢嘅 personality 係點啊，點解佢會 arrive at 呢一個咁樣嘅 decision 等等，呢啲非常之有用嘅嘢。你哋作為 practitioner of 呢個 narrative approach 嘅人，你會唔會覺得可以去 advocate 翻俾policy makers， 睇下點樣可以改變個 social environment， 其實呢個係今日其中一個 theme 啦，去 facilitate 啊，即係一個 environment 係 conducive， 可以做到呢啲咁有意義嘅工作咯。Thank you。
我呢啲喺個食物鏈下邊嗰個階層咧，我唔知答唔答得啊！即係我都好想，即係其實就係我啲同事冇機會做、冇時間做咧，我先有機會做。即係如果佢哋有時間做咧，我就冇機會做㗎。咁我冇機會聽到呢啲古仔。的確翻去，即係如果我着翻套制服咧，我就要跑數嘅咁。我估喺公家裏邊，我哋真係好難去即係希望每一個同事都做得到，因為我估呢個係一個社會論述嘅問題。我哋呢個 KPI 呢個係我哋好緊要嘅一個 dominant 嘅 discourse 嚟嘅咁。但係我估有時個narrative therapy， 我估佢未必一定要係我哋傳統諗嘅嗰種 therapy。即係坐喺度50分鐘嘅一個 therapeutic hour 咁啊！我印象中我學 narrative therapy 嘅時候，我接觸我老師丁媽咁，同佢其實由一個課室行去另一個課室咧，就傾嗰陣就已經 narrative 咗啦。有一次我約佢行山，因為咁啱我約佢行山前就發生咗啲事，唔係好開心。全程佢都冇同我講過問題嘅，但係落完山之後咧，我就突然間如沐春風。即係佢冇同我討論過問題嘅，但係突然之間我就落山嘅時候就好多 reflection。我估所以其實未必係一定要用嗰個形式或者嗰個局限嗰個框架底下點樣做，而係頭先我講嘅敘事係一個哲學嚟嘅。如果大家有嗰個哲學，即係李小龍咁樣四兩撥千斤咁，你乜嘢都可以四兩撥千斤嘅。你唔一定要着李小龍裝，有個雙節棍先可以四兩撥千斤。你可以平時都可以做到呢樣嘢，即係可能一個護士嘅同事幫個病人抽緊血嘅時候，同佢傾偈嘅時候，其實嗰個敘事嘅哲學都可以一樣出到嚟嘅咁樣。咁而敘事治療從來都冇話要一個註冊嘅敘事治療師嘅原因，係因為係每一個人都可以成為一個敘事嘅 conversation partner 嘅咁樣。所以我估呢個都可能係跳出個 KPI 以外，我哋可以去思考點樣將呢啲 skills 或者個哲學帶落去我哋每一個做呢個行業嘅人咯。
Maybe sorry. Yeah, I just want to translate, a little bit, so that Dr. Tang, maybe any input, in the Singapore context, because we've been talking about like how to been using like narrative practice sometimes in the system, like it takes long time to talk to the service user, and sometimes the KPI or environment may not allow that. Is there any way that we can advocate, like system and the people, practitioners, like how to adopt some of the approaches, for example, like narrative approaches, and also I think the approaches that you mentioned, the trauma-informed, approaches, etc. How to, advocate, like the environment, the medical professionals in a very stressful environment, but still they can do something, any experience? And 大家互相夾。我哋講埋 narrative 就等啊。可以講嘅。非常之
中意呢個提問，因為其實咧我自己大學裏邊係教敘事㗎啦。咁人哋咧我有 counseling 嘅學生啦，有社工嘅學生啦。其實佢哋成日翻嚟都係話俾我哋聽咧，就係話佢一去到翻機構做嘢嘅時候咧，或者特別做實習嘅時候咧，佢哋就碰到好大嘅問題咧，就用敘事填唔到啲 form 嘅。咁咧因為大家都知嗰啲 form 嗰啲 intake form 啊，嗰啲全部都係要佢填，譬如話你覺得佢嘅問題係乜？係啦，即係我哋好快要做一個即係problem 嘅 assessment， 或者你要話佢個問題喺邊，然之後你要話你個 treatment 係乜嘢，你個 intervention 係乜嘢。咁敘事咧就都係有我哋好啲比較特別嘅脈絡㗎嘛，即係我哋唔係行入去就問你個問題喺邊，我哋就調翻轉，可能就係話覺得呢個問題唔係你個問題，然之後我哋大家一齊去傾下呢樣嘢咁。咁所以係真嘅，即係好多喺 NGO 嘅 context 或者我唔知 medical 係咪都有咁嘅狀況咧，就係話其實啲上司或者係啲 supervisors 冇乜呢個耐性嚇，即係你唔好話俾我聽，你同佢傾好多個 section 之後先講到俾我聽，即係你做緊啲乜嘢咁樣。咁而家我都俾我自己一個挑戰嘅，我就開始諗咧，我點樣可以即係同大家分享到，或者我哋一齊去諗下，就係一啲好 conventional 嘅 service setting， 或者係佢唔係好覺得你要用呢啲嘢嘅時候，我仍然好似頭先 Barry 講，我都能夠擺到嗰啲概念落去，然之後我又交到功課嘅。即我而家係俾我自己，因為年啲學生都嚟問，一出實習就做唔到啦。佢哋好中意呢個 approach， 個個都話要做。但係一落到機構一做 counseling 做唔到，因為佢答唔到嗰啲問題，係啦。咁我而家開始諗我點樣去預備到，要同阿 Barry 分享。
版嚟嘅啫，版嗰啲點樣寫其實睇過。
冇錯啦，即係叫佢哋可唔可以即係唔好咁 serious about those reports。I'm sorry。
我都係有份問阿 Kensley。個 outcome 咧用呢個 approach 你會諗點樣 narrate 個 outcome 俾我聽？你可以用 narrative approach， 你要 narrate 個 outcome in a systematic way so that I can talk to the funder, I can talk to the people。係啊，
我 trauma 嚟嘅呢個。
Another question
inform 我同佢傾嘅時候
，Another question that we have been asked always is about evidence of effectiveness. You know, so we are always asked, are there any research studies that you can prove the effectiveness of narrative therapy or narrative practice? But to be frank, actually we are very much underdeveloped in terms of doing scientific research because we don't agree with the ideas of scientific research. We are not CBT. We are not some of those very long history approaches that were well established in terms of research findings and so on. So that's one of our disadvantage, I think.
No, I'll keep it really short. But I heard, was it 15 minutes? I something about like how long it takes to do narrative, like.
It could be long, but it could be short.
Right.
Yeah.
Okay.
It doesn't really take any specific time to really do a session. I mean, we sometimes call it a conversation rather than really a therapy, because you can bring in the philosophy into the conversation without really thinking about you have to do. We don't have an agenda like CBT.
Right.
I mean, in narrative therapy.
Okay.
That makes some sense.
Yeah, I think, I don't know, because I do some research on like integration, and I think about like maybe community-led kind of approaches, and how communities can help enhance health systems also, because not everything has to be done by a physician, and I think a lot of times it's the policies that say physicians must do it, but I've seen models where communities take parts of it that, or they are supervised by a physician. So I wonder sometimes whether for some of different approaches, whether there's also a possibility where like aspects of it, you can task shift, shift the task to like some other people. I mean, there are also expertise in like I'm pretty sure like narrative approaches have its own like expertise that you need to be trained in. I think you cannot take that away from people who are trained in like psychotherapy, but thinking about how everyone can work together is not just a job of the therapist or the physician to make things happen. I think we often forget that, but I also know that sometimes policies prevent us from
going there, and KPIs also prevent us from doing that.
It's very off-putting.
Thank you so much. Actually, what Dr. Tang shared, we will continue the discussions in this afternoon, because we'll be talking about like how the GO NGO can work together to create or co-create a service model. So, okay, thank you so much. Thank you. Okay, 我知道大家好肚餓㗎啦，咁而家咧就係lunch hour, so we'll have like 1 hour. Okay, so we'll be back in an hour, and then we'll have another discussions on the physical health and the social health. Thank you.
At Gilead, we have been committed to delivering person-centric advances in HIV research for more than 35 years. Our latest innovation spotlight will focus on the concept of drug resistance. Drug resistance can impact the selection of treatment regimens and is an important area of our long-term HIV treatment research. HIV drug resistance is caused by mutations in the genetic structure of HIV that may affect the ability of medicines to block the replication of the virus. All antiretroviral drugs, including those from newer drug classes, are at risk of becoming partially or fully inactive due to the emergence of drug-resistant virus. Today's treatment regimens are highly effective at lowering the amount of HIV in the body when taken as prescribed. However, the virus may be resistant to treatment for several reasons, including past treatment failure due to resistance development, challenges with medication adherence, or acquiring drug-resistant strains of virus. If HIV does begin to replicate once again, the virus may also gain the ability to evade certain medicines that were previously effective. This creates the potential for development of resistant strains of the virus that may be passed on to others who also may now have fewer effective treatment options available to them. Drug resistance is a key area of focus for our long-term HIV treatment research. Scientific discovery will